Good evening and welcome to Fresh Natural Live. Hope you had a great weekend. We are here April 19th, 2021. And, we talk a lot about natural remedies, natural treatments, supplements, nutrition for different health conditions. But, what if you or a loved one is acutely ill? What if, a loved one is in the throes of a heart attack or is in the hospital, in the ICU? Or is acutely short of breath, someone who's critically ill, maybe even in the emergency room, suffering a heart attack, get an emergency heart catheterization, who's scheduled for an urgent surgical procedure for an infection or the like. Can that individual benefit, from natural approaches? And we tend to think, acute care medicine is for the acutely ill. Yes, if you're having a heart attack, get a heart catheterization, in my line of work. But can people who are acutely ill, severe heart failure patients, severe lung disease patients, can they benefit from nutritional medicine? Can they benefit from supplements? Can they benefit from these types of treatments, even in that acutely ill state? Well, we're going to find out today. And we're going to have a very, very interesting conversation regarding this topic. So sit back, get comfortable, and get ready for a very enlightening show. Hello again, and good evening. Happy Monday to you all. I hope you had a wonderful day here in this part of the country. Had a beautiful weather today. But I'm excited about this show tonight. It's something that's near and dear to my heart because when I got into this arena of natural treatment, it came through the nutritional side. I personally experienced what it was like to do a juice feast, a detox, and felt great. But then I started applying it to the care of my patients, many of whom were very ill. Although they were very ill, they were in the office setting. However, I started seeing patients who were more acutely ill, and we started applying it to these patients. And I was quite surprised in terms of what the results I got. And I'm going to share some of that with you tonight in our discussion for the food prescription for chronic disease. We're going to look at not only patients with chronic illnesses, but aspects of acute illness. And we're going to look at, examine how natural approaches, whether it's nutrition or supplements, can work in these patients and how it can be effective. And we're going to look at some scientific evidence to show the mechanism as to how this is working. So this is going to be a great show. But before I go on, I want to bring two of my esteemed colleagues on. Dr. Celeste Palmer, how are you doing this evening?
Good afternoon. Good evening.
And Dr. Floyd Atkins, how are you today, sir?
Doing wonderful, doing wonderful.
Okay. So as I said at the outset, we're going to discuss the food prescription for chronic disease. And really it's natural approaches for, treating people with chronic illness. But not only just who are chronically ill and stable, but people who are acutely ill. You're having a heart attack or you're in heart failure, lung exacerbations, cardiac arrhythmias and various things like that. And we've run the gamut in terms of patients who present to us, even in our office, with heart attacks or various, other acute illnesses in the hospital emergency room. And, so can these patients benefit from a nutritional detox in addition to these acute treatments? And, many of you can probably guess that my argument will be that yes, they can. But I want to really go and examine, how and why. And so that's going to be the topic of subject matter topic tonight. I'm going to share some slides with everyone tonight. First, I want to say hello to Catherine Welch and Shonda's Real Food and Drinks. Get My Own. Hello, happy Monday to you. Flea Bite Girl with all the wonderful questions. Barbara Perlis and Karen M. Evans. Good evening, welcome. And Yolanda Yvonne Williams, who has a comment, Washington, D.C. viewer learned of trachea relief of marijuana from lupus. Interesting, related to our topic last. So what is the Montgomery Wellness April 1920 position on the natural treatment and yet legal Texas? I don't know about the legal aspects of this. We're going to bring some experts on cannabis later on. I met some physicians up in the Oregon area. So Yolanda, we're going to have some real experts on pretty soon to talk about that topic. April Hocut, welcome. So without further ado, I'm going to share my slides with everyone. So the food RX for chronic illness, chronic disease. First of all, let's look at what is chronic disease. As we all know, chronic disease, chronic by definition, is an adverse condition that's expected to last a long period of time. We arbitrarily say more than a year. There are key chronic illnesses that we all think about when we hear the term or phrase chronic illness. There's heart disease, cancer, diabetes, lung disease, arthritis, chronic infections. There are many others that can tie into this, chronic infections of other types and the like. So when we think of chronic diseases, when I like to think of an underlying process or processes that's keeping that disease state going. And first and foremost, I think of inflammation. Inflammation, like a biochemical fire. It's when the body's immune system is revved up. Frequently, it's revved up on an ongoing basis. And so it's like the analogy I frequently use is charcoal that's smoldering on a barbecue pit. And so you get the charcoal hot, and so they just smolder there. So that's the ongoing chronic inflammation. And then you could have a flare up if you put the lighter fluid, spray lighter fluid on the smoldering charcoal, the flame flares up. And so these chronic illnesses, which is sort of like smoldering biochemical fires, can flare up. And that's an acute episode, an acute exacerbation of lung disease, acute exacerbation of arthritis. So a major underlying process is inflammation. Another underlying process is oxidative stress. So what is oxidative stress? Oxidative stress is really toxic chemical buildup. And we've talked about this in some of our other discussions. And so you get free radicals, the molecules that are missing an electron, and they become unstable. So they fly around and they cause damage. They damage cells, tissue, and eventually organs and organ systems. A good analogy is an apple that over time can oxidize. And that's an apple that has increased oxidative stress. And we've seen apples that turn brown and become all cruddy looking. Analogous to that would be a cell that starts off normal, but if it's exposed to too much oxidation through abnormal cells, it causes excess oxidative stress. And many people are walking around with excess oxidative stress. Their organs are not working right. Their kidneys are dysfunctional, the heart's dysfunctional, liver, etc. And so, this is an ongoing process that's contributing to the chronic illness. In the third area, I don't talk about a lot, but dysbiosis or a dysfunctional microbiome. Lots of us have abnormal gut flora. We use lots of antibiotics. People that consume, dead animal flesh on a regular basis, these animals are treated with antibiotics, and that might be the biggest source of antibiotic consumption is the consumption of animal protein. And there are other things, prescription medications, where you live, life stages, stress. And so many of these things affect the microbiome. There are positive things that affect the microbiome. If a baby's breastfed versus bottle fed, breastfed is better for the microbiome. And there's a historical aspect of things. So if you were breastfed as a baby, or you had a natural life, you grew up on a farm, you had a microbiome that, developed in a healthy manner, and that set a course of healthiness. Maybe if you were bottle fed and ate chemical toxic foods from a very young age, your baseline microbiome is terrible, and so that sets you off to a negative course. So there's a historical aspect of the development of your microbiome. Maybe there's a congenital microbiome syndrome. Maybe we'll have to ask Dr. Palmer to talk about that one day. But the microbiome clearly is an area that is important. So I'd like for us to keep those three main areas in mind and when we talk about chronic illness, because it's not that someone has diabetes or heart disease or whatever. They have an underlying process that's manifesting itself as heart disease, diabetes, et cetera. So those are the things that we look at. So I want to get into a little bit of clinical medicine. I don't want to bore you to death, but I think it's important for us to talk about, okay, how do I deal with a patient who comes in and they're very sick? Yes, there's some acute things we do, but then how do we integrate the nutritional part with that? And so I'm just going to put you in the natural setting of a clinical exam. So a patient comes in the office and they say, well, I've got shortness of breath, or, I've been passing out, I've got chest pain, I'm nauseated. We start off with the history and the physical. We talk about the onset, how acute it is, is it chronic? Because someone who, is short of breath, has been short of breath for 20 years and the same shortness of breath today as it was 20 years ago, that's a chronic, stable process. But if someone walked in my office, today and said, I became acutely short of breath last night, my legs are swollen, I'm a little bit sweaty and short, the oxygen level's low. That's a process that happened last night. It didn't exist the day before, yesterday in the morning, or the day before. And so that's a process that's more acute. So a history and physical exam helps out and determine the level of acuity of the problem as well as what the problem is. And we were taught in medical school that, the history and physical gives you about 85 to 95% chance of making the diagnosis. And then what the testing you do is really to confirm your clinical impression. Biomarkers are important. We get a lot of blood tests that determine your blood count, your thyroid function, electrolytes, et cetera, et cetera. We do non-invasive tests in the office, and sometimes patients have to be admitted to the hospital for either close hospital observation or invasive testing. So this is the outset at the beginning. So the integrative intervention has several components to it. So when we see the patient, first we look at the medications. And what are you taking? Because it's I shouldn't say it's not unusual, but it's usual for us to have a patient that's on 5 or more medications, frequently 10, 15, or 20. So we're looking at the medication because oftentimes some of the symptoms may be due to medication side effects. And I'll show you some clinical examples of that later on. So review the medication list, make necessary changes, revise doses. We try to remove any unnecessary medication. We discontinue all. And if they need intravenous medications or diuretics, whatever the case is, we will treat them with that. But by and large, when we've seen someone and they're going through our nutrition program and our detox program, we take control of all of the medication, the cardiac and non-cardiac. Now, we will consult with the other physicians if need be based on change we have to make. But we take control of all of the medications because we feel that we need to make adjustments, especially if they're starting on a nutritional detox program where they will be making, rapid change. Their bodies will be going through the rapid changes, and we may need to adjust the medication accordingly. Plus, we see the patient very frequently, and it's hard for them to get to see other doctors as frequently as we see them. So the next aspect of the food prescription. Now, the food prescription starts off with an assessment. What are you eating now? I mean, someone may be eating fried chicken every day. For someone else, I've been eating a, whole food plant-based diet for 10 years. Our approach will be different for those two patients. We'll analyze in one case, okay, how are you preparing your whole food plant-based diet versus, okay, we're going to stop the fried chicken. Overall health condition, are they exercising or not? Are they able to exercise? The level of functional status determines, gives a clue to their health. So if someone says, well, I don't get short of breath, but I sit on the couch all day. Well, okay. You may have bad heart disease. We're just not stressing yourself enough to determine whether you have significant heart disease or heart failure, whatever the case is. So we look at, the nutritional status, also look at the overall health status in terms of functional status and activity level. The next thing is we look at the options for doing minimally invasive testing. We do echocardiograms and various things in the office. We can give IV fluids or IV medication in the office, but sometimes it needs to be brought into the hospital. for hospital procedures. But again, we do cardiac counterpulsation test. There's a cardiac assist test for patients with angina or heart failure. We can do monitoring, implants, and things like that. So there's a lot we can do in the office to, minimize the need for admitting patients to the hospital. We have some heart failure patients that we may give IV diuretics to today, watch them diurese some in the office and have them come back the next day, check their electrolytes and things like that. But then some people may need to be hospitalized emergently or urgently based on their clinical condition. So we make that assessment. That assessment is based on their stability. So what is the patient's clinical condition? We break it down into several categories. You have the acutely ill. We've had people come into office in ventricular tachycardia, heart attacks, pulmonary embolism, cardiac arrest. We've had the whole spectrum of things, and we have to deal with that and get them into the hospital. If they're chronically ill and compromised, they may not be so acutely ill. So maybe they're short of breath. I had some patients in decompensated heart failure. I give diuretics, check their electrolytes, have them come back the next day. And if they're much better, we'll follow them multiple days in a week. Or, if they don't do well after a few days of trying, then we'll put them in the hospital. So it's either frequent outpatient visits or urgent hospitalization. Then there's a critically ill. They may be critically ill and stable with mild symptoms. Then we can start their nutritional detox and do frequent outpatient management and interventions. And then the chronically ill without symptoms. Say, well, I have a history of high blood pressure, high cholesterol, and I want to get it under control, but I'm going on vacation. The next 2 weeks, I like to get started when we come back. Okay, fine, we can do that. Maybe we'll tweak your meds. Maybe we'll wait till you come back. So that's the spectrum of what we deal with and how we manage patients. Let's take a closer look at the food aspect of things. So, we utilize a well-designed and organized, I like to say well-designed, organized. It's a biased opinion on that one, but we call it the food prescription system. And it's based on a systematic way of classifying foods. It's not enough to say, oh, go eat a healthy diet, or, oh, cut your carbs, or, oh, eat vegan, or whole food plant-based, or whatever the case is. I mean, those are broad, descriptive, terms and phrases. But when it comes down to it, what does the patient eat and how do they prepare what they eat? And so we've come up with a system. It's based on a classification scheme that's based on 0 to 10, 0 being the most healthy, 10 being the least healthy. It utilizes 5 basic characteristics of food to determine what makes it healthy. Fundamental source or origin, is it a plant or animal, an inorganic mineral source, or synthetic? Is it, made from a machine, or did it grow from the earth? Conditions of development, did it grow in an organic, pristine environment, or did it grow in a, chemicalized, area that has all sorts of toxins in the soil and toxins in the air? What was the level of processing? Did it have a lot of preservatives added to it? Has it been fried or microwaved? Basic chemical characteristics, is it hydrating? And things like that. And what effects on the human body does it have? So, these are the basic characteristics that gives us that classification scheme. And so, in essence, the overall benefits is that it provides us with some structure, and it goes beyond the usual calorie counting and portion measuring. I was talking to a nutritionist today about one of our critically ill patients, and he's saying, well, what do you think about the calories? I said, well, I don't think anybody thinks about the calories. I think we should let her eat to satisfaction. We're going to continue to nourish the body. Oftentimes, sick patients, don't need to eat a lot of calories. I mean, we're in the hospital. They try to force feed. They need their caloric intake, 2,000 calories or whatever. I wouldn't say that they need to be fasting the whole time, but if they can only drink one smoothie or one salad, let them do that, or whatever the case is. Or they can fast if they're very acutely ill for that short period of time for 2 or 3 days, and then we keep them hydrated and then let them nourish themselves as they recover. It allows for evaluating efficacy, and it enables us to provide therapeutic precision. So efficacy meaning if sometimes I'll put patients on food level 0 to 6 and they're not getting well, then I put them back to 0 to 4B. Or I may start them on 0 to 4B, they do well. Then after the detox, go to 0 to 6, they regress, and we go back to 0 to 4B. And so it gives us a way of measuring efficacy at different food levels. It allows for therapeutic prescription accuracy as well. Now, here, what I'm going to do is I'm going to show a little bit about the nomenclature. This slide looks a little busy, but I'm just going to break it down for you. Don't worry about memorizing everything. It's all here, and you can maybe take a picture of it and go back to it later. But when I talk to my clinical people, we provide them with a food prescription. And we use this with intermittent fasting. So if somebody's doing intermittent fasting or not doing intermittent fasting, we'll put them on one of these regimens. So the first position here, it denotes the time duration of the feasting hours. So if you have a certain day that you're doing an intermittent fast on that day, there's a certain number of hours that you're feasting. That number of hours can be in the first position. The second position denotes the duration of fasting on that day. The third position denotes the number of days you're doing the intermittent fasting. And the fourth position denotes days that you're doing complete fasting. Now, as a footnote, we all intermittent fast. I mean, unless we're up 24 hours a day, eating 24 hours a day. But when we're sleeping, we're fasting. And so everybody's on an intermittent fast naturally. So because, I do intermittent fasting. Well, so do I. I go to sleep. We all go to sleep, so we all intermittently fast. So the intermittent fast, we kind of stretch that period of time. So if you sleep 8 hours, we may stretch that fasting time beyond those 8 hours. So you may add 4 hours on either end of that sleep time to get 16 hours of fasting, or 5 hours or whatever the case is, and get 20 hours. So the intermittent fasting is sort of stretching the normal intermittent fasting time. And then we have a day of complete fasting where you're just only drinking water. And then the area in parentheses denote the food level that you're eating at. So a lot of people say, I intermittently fast. Okay, great. When you're eating, what do you eat? Well, fried chicken, pizza, and that type. Okay, that's great. But, you're destroying the whatever benefits you're getting from intermittent fasting. So the intermittent fasting period could be even more aggressive if you're doing an intermittent fast. When I walk you through these two prescriptions, when the feasting part is only raw juice, or the feasting part is only raw foods, or the feasting part can be 0 to 6. So let's take this first one. This is a 420, 5-2, 0 to 4B. So this person is going to be doing intermittent fasting for 5 days out of the 7 days in a week. And they're going to feast for 4 hours, fast and sleep for 20 hours. So if they're sleeping 8, they're going to be drinking water for 12 hours, 5 days a week. And then 2 days of the week, they're going to be doing just nothing but water. And when they're feasting during these 4 hours, they can eat food levels 0 to 4B. This patient was a 427-0-0. They have intermittent fasting, where it's 4 hours a day. They're going to be feasting, 20 hours fasting, and they're going to do that for 7 days. They won't have any days of complete fasting. And when they're feasting, they're only going to be drinking either raw juice or just drinking juice and smoothies. So they're at food level 0. So this is two examples of a prescription, and we can make these prescriptions more aggressive or less aggressive depending on the sickness of the patient. People with systemic inflammatory conditions or GI problems, you may put on a more aggressive one to rest the GI system. We may put someone on a lesser aggressive one to start them off more easily. So this gives you an example of the level of precision in which we, prescribe the food and along with the intermittent fasting. Now, let's look at some clinical intervention supplements. We've talked a lot about supplements. They do have a role. We like to supplement using superfoods and some basic elemental things, and then we supplement other things like vitamins and the like based on an as-need basis. So what I'm going to give you here is just kind of the broad areas the foundational supplements that we use. There's some other things that could be foundation, but these are some of the very basic ones, especially if someone who's acutely ill. So superfoods, there can be a blue-green algae. It could be one of the freeze-dried superfood powders that have organic greens, organic broccoli, and that type of thing, or spirulina, moringa, sea moss. These are examples of some superfoods that we use interchangeably for our patients. The MSM is anti-inflammatory, enhances the production of glutathione. We use a liposomal vitamin C, which has antioxidant effects and reduces oxidative stress, anti-inflammatory effects and reduces oxidative stress. Liposomal curcumin, especially when a patient has a systemic inflammatory condition. I was taking care of a patient with heart failure and bad lupus, has systemic inflammatory condition that's probably exacerbating that. So I'll add the curcumin along with the vitamin C. And if they have heart failure, we're really big about giving them liposomal coenzyme Q10. These things collectively reduce inflammation and oxidative stress. They enhance cellular function. So we're trying to work at the cellular level with the food and with some basic supplements. Yes, vitamin D is important, especially if someone's D deficient. B12 is important. These are also very important supplements that we use. We tend to measure these vitamins and then replace as needed. Now, clinical interventions from the medication standpoint. We have a protocol in which we optimize or wean medication. This is very important because, as I said before, many of our patients are coming in on 5 or more medications. And so, how do we address these medications? Well, at the baseline, so I'm seeing someone at the beginning, they say, okay, I want to start a detox. I'm starting tomorrow. What do we do? I got 21 medications. I'll take a look at the list. Oftentimes they may have over-the-counter vitamins or supplements. We'll get rid of those. A lot of times diuretics may be among the first things we'll remove. And also insulin or sulfonylureas, anything that can drop the blood glucose, especially if their blood sugars are controlled on these, because when they get on the nutritional regimen, the detox, the blood sugar will go down more. And let's say your blood sugar is running 120 to 130 or even 140 or 150, I don't know, and you're on insulin. It's better to stop the insulin, and I'd rather run the risk of letting your blood sugar run up to 300 than let it run down to 30 or 20 or 10 or 5, because that too low number will put you in a coma. We go to 300, 500, 600, you can call me and say, hey, my blood sugar is 600. Okay, take some insulin. But it goes down to 3, you can't call me. And somebody else is calling saying they're in the coma, they're not waking up. What do we do? And so, we rather run the risk of running high. So we stop these and give it on an as needed basis. If the blood sugar goes above a certain level, usually it's 200 or 250, depending on what their baseline ranges are. After week 1, again, we assess the patient. Oftentimes we can decrease the blood pressure medicine by 1/4 to 1/2. If the diuretics have been reduced and not removed, we'll discontinue them frequently, especially if we see that the blood pressure is coming down, they appear to be a little bit dehydrated. And other medication, calcium channel blocks, ACE inhibitors, all these are looked at and may be weaned or discontinued at this time. On week 2, if we haven't taken off things like NSAIDs or proton pump inhibitors or steroids, we start to wean these at this time. Oftentimes it depends on the clinical scenario. If somebody has real bad arthritis, we may put them on a liposomal curcumin, see if they get relief, and then maybe have them, take the NSAIDs or steroids as needed or go every other day or something like that. Inhalers, we tend to wean these off at least by the 2nd week, oftentimes sooner than that. And week 3 and 4 in the detox, we continue to wean other medications, make adjustments. We may add a medication that we think is more effective and allow us to take away 2, say, blood pressure medication, for instance. So we can reduce and simplify the medications and reduce the drug-drug interaction while we're trying to do the overall medication wean. So clinical intervention, more invasive things. So if someone's more ill, they come in with decompensated heart failure, they're short of breath. I remember one patient came in, he could hardly talk. He got an echo, his heart's beating about 10, 15%. He was a dementis and said, look, you need to go to the emergency room. So no, I'm not going to go to the emergency room. And so we gave him, I think, maybe 60 to 80 units of furosemide IV in the office. And, we observed him. He went to the bathroom several times, and heck, he walked out smiling and feeling much better. We saw him the very next day. So there's some things we can do in the office. Excuse me. IV therapy, whether it's IV fluids or diuretics. We do vein ablation procedure. There's lymphedema therapy that we can map them for, and they get these little machines that they take home. We can implant monitors and various other things, fluid injections or the like. So there's some things we can do in the office to help keep them from having to go to the hospital or emergency room and that's been found to be useful. However, on some occasions, we have to take them to the hospital, general admissions, and frequently if they're acutely ill, they may have to go for an emergency procedure. I don't do procedures anymore. Recently turned it over to my colleagues, but there's a patient getting a heart cath and an electrical study, and they may need to get device implants. But all of this is done in the context of natural treatment, and we'll talk about how we do that. So just because you may need something done acutely, not only does it not mean you don't need, say, to be on a nutritional detox or maybe some basic supplements. If you need some acute therapy, heart surgery or whatever, you definitely need to be on a detox in the perioperative phase. And you definitely need to be on superfood supplements that's going to help your body recover. So I think these things are not only helpful, but in my opinion, absolutely necessary. Let's go through some clinical examples to kind of help put all this together and bring it home. So this is a 65-year-old man, had known heart disease, and he had prior multiple heart attacks, prior stents. He was in heart failure. His ejection fraction was 35 to 40%. And so he went to the emergency room the day before, maybe 1 or 2 days over the weekend, whatever it was, and was having chest pain. And they got the troponin enzymes, a blood test they get to see if you're having a heart attack. They checked them, and it was quote unquote negative. Now they measure troponins at nanograms per ml. In the office, we can measure the same troponin levels at picograms per ml. So it's a more sensitive test, but they're looking for troponin leakage that indicates heart attack or cell death. We're looking at troponin levels that indicate cell stress, not necessarily death. And I'm going to show you what we found in the same patient. He had a known history of angina, heart failure, as I mentioned. And so our intervention was to evaluate him in the office. So he was discharged from the emergency room. We saw him that next Monday, and we did a clinical evaluation. We made adjustments in his medication, and we started him on a nutritional detox. So we checked, as I mentioned, the troponin level. Now, with this patient, I want to just look at the troponin level. We did other labs too, but I want to show you the change in troponin levels because here's someone who's having chest pain, known coronary disease, heart failure. So we were measuring the amount of myocardial stress. So the troponin level that we measured, as I said before, in picograms per ml. Now, we measured 28 picograms. If you measure some nanograms, you have to put some more zeros in front of this, and it come out essentially zero in the emergency room or very low. So at 28 picograms per ml, we know that his heart is in increased stress. Above 10, the data shows that above 10 picograms per ml, you're at risk for future cardiac events in the near future. So we felt that we need to get this down. So what we did, and by the way, this little paragraph here tells you troponin is a part of a complex set of regulatory proteins. It's part of the contractile unit of skeletal and cardiac muscle. And so when the muscle tissue is under stress or dying, it leaks out these proteins, and we can measure them in the blood. So just as an FYI. Now, so we started on a detox here, and after 1 week of detox, the troponin level went from 28 picograms down to 5.7. Stayed down below 10, but then bounced up a little bit. Now, we were tweaking his medication. At this time, we removed the glipizide. There's data showing that glipizide can cause ischemia or abnormal blood flow in heart tissue cells. They've done that with rat models. So it probably could be the same in humans. So we stopped the glipizide, and his troponin levels came back down. Just to show you the graphical display, notice this rapid decline in just 7 days. And I would even argue that if we were to draw in it 1, 2, 3, 4, 5 days, you probably would have seen a very rapid drop. Point is simply this. The nutritional detox in this setting caused a very rapid and immediate reduction in stress in the heart. That's the nutrition. He was in the hospital, ruled out for MI, could have had a heart cath, could have gotten a stent, but it was the food that caused a rapid drop in the amount of stress in the heart in a matter of days. And so we see that, and although it bounced around, as you can see, this critical line of 10, we stay below that most of the time. So the detox caused a drop. The reducing the medication weaning helped out, and we stayed below this critical 10 picograms per ml. So again, this scenario shows you how rapid the nutritional detox
Quick
works. So people, yes,
Was he in the hospital during that 1 week? Like,
no, he was in the hospital. He was in the office. He was an outpatient.
He was outpatient.
So, yeah, so he went to the emergency room. He was having chest. Great question. Having chest pain. They discharge him. Say, and they, in fact, I talked to the emergency room doctors, and so they said, "Oh, he's having chest pain, but he ruled out. We know you're his cardiologist. Can you see him Monday?" Yes. And so they discharged him with that, and so we detoxed him in that period of time, and was walking him through that whole process with some phone calls, visits in between. Mm-hmm. So, and I'm glad you asked that. I don't think I made that clear to everyone. So, reduce chest pain, reduce shortness of breath, improve energy level overall in that 4-week period of time. Case 2, a 60-year-old man and who was acutely ill came, and I'm not sure, I may have presented this either on this show or Detox Me Now, but I want to point out some different aspects than what I may have pointed out before. He was 60-year-old, came in, and his primary physician had called me and said, "Look, this Mr. So-and-so, he's, pretty ill. And so, can you see him today?" I said, "Yeah, we can see him." And so he came in, high BMI, blood pressure elevated, heart rate 122, and he looked pretty sick. He was edematous. His legs were swollen, abdomen was swollen. And I did an EKG, and he was in an abnormal heart rhythm called atrial flutter. It's when the upper chamber beats very rapidly and semi-control, not total normal control, and it caused the lower chamber to beat rapidly. So that can also contribute to the shortness of breath, and it also decreases the function of the heart. So the total circulation can be decreased because the heart is beating so fast and in a not so orderly fashion. So we admitted him. And here's the EKG showing the flutter. I'm not going to, bore you with the EKGs, but if you see this little sawtooth pattern in the inferior leads, that's typical counterclockwise flutter. You don't see the little P waves there, and so on. So when we got the blood work, so next I'm going to show you his hospital course over several weeks. Some is in the hospital, some is outpatient. His creatinine started about 3.25, and the higher the creatinine, the worse the kidney function. But he detoxed in the hospital. Now, this time he was in the hospital most of his time, and we put him on detox. He was on raw fruits and vegetables, and the hospital is not as exciting as our food. He did have some people bring some of our food from our kitchen. He ate some of the hospital raw food, and he stayed on the detox, and his kidney function got better. We see the GFR, glomerular filtration rate. That stands for how well the kidneys are filtering the blood. So the lower the filtration rate, the worse the kidney function. The higher the filtration rate, the better the kidney function. And his filtration rate improved significantly over this time. Normal is greater than 60, ideally greater than 90. He almost got to normal. Now this slide is pretty interesting. Albumin is the main protein that we measure in the blood. So people say, "Oh, where do you get your protein from?" So when he came to us, he was on the standard American diet, and his albumin level's 1.7 right here. Normal is 4, so it's less than half normal. So he had low protein on a standard American high animal protein diet. So we put him on detox, raw fruits and vegetables only. In the hospital, eating mostly lettuce and tomatoes and fruit, etc. On the raw detox diet, the protein went up almost to normal, not quite to normal. Now he was discharged, and somewhere along here, he got a hold of some oyster soup and gumbo and some other stuff with animal protein in it. So when he ate the dead animal flesh, guess what? His serum protein went down. He also got sicker and swollen and so on, almost down to 1.7. What do? Put him back on a raw detox, mostly smoothies. On raw detox, lettuce and smoothies and greens, protein went up. So then you ask, well, wait a minute, what's going on here? If he's eating animal protein, why is the serum protein low? And then when he eat, grass and water, the protein goes up. animal protein goes low, grass and water goes up. Well, this gets to an important factor, and I talk about it from time to time. Typically, in the patients I see who are chronically ill adults, the albumin level or protein, serum protein level, because albumin is not the only serum protein, but it's one that we use as a monitor of serum protein. It's easy to measure. But your serum albumin is often low for two major reasons. One is inflammation. In the setting of inflammation, the capillary windows open up, and the albumin molecule can seep out through those capillary windows. Normally, capillaries are tight, and it allow certain nutrients things to pass by. But with inflammation, those capillaries, they loosen up, and they become the gaps form in them, and albumin seeps out. So the albumin leaks. Inflammation is number one. Number two is hepatic dysfunction. Lots of people have liver dysfunction. They have non-alcoholic fatty liver, oftentimes due to all the chemical preservatives and junk food and things that they're eating. So in this situation, the liver is not functioning normal. It's not able to produce proteins such as albumin. And so a lot of people with fatty liver, even without fatty liver, you have early liver dysfunction and albumin levels may be low. A third area, which I don't see a lot of, but I think it's probably more common than what we know, is malabsorption. And these may be people with a real bad gut flora. If somebody's on a lot of antibiotics, they've been on chronic antibiotics for whatever reason, their microbiome may be dysfunctional, so their gut's not breaking down nutrients and they're not absorbing things very well. So the albumin might be low in that setting as well. So with this patient, with his detox overall, when he complied with greater than 50% medication reduction, his heart rate and rhythm was controlled. That was partly due to a cardioversion. Leg swelling went down when the albumin level went up. And he had overall improvement in his clinical well-being with the plant-based diet. So I just want to show, again, the acuity. Here you saw days to weeks, you saw improvement. The other patient, similarly, days. This is the final case scenario I'm going to show you. I think I presented this on this Fresh Natural Live before. So I'm going to go through this one. But again, I wanted to show some of the acuity, rapidness in which he improved, and show some of the things that we did. So this is a gentleman that had type 2 diabetes, had a previous stroke, hyperlipidemia, had severe heart failure, and he was on the heart transplant list. He flew in from the East Coast, presented to us with substernal chest tightness. He was on a lot of medication, which I'll show you in a minute, and he had not seen his doctor in 8 months. Now, it offered LVAD, transplant, COVID hit, and that kind of delayed travel, and doctors weren't seeing a lot of patients in the office, et cetera, et cetera. He thought his ejection fraction had passed was less than 20%, but it was like a year prior to that. So here's the medication list he was on. He had a history of gout. He's on allopurinol for that, magnesium. Carvedilol is a medication called a beta block. It's for heart failure. Tradential is for his diabetes. Eliquis. I think he had some cardiac arrhythmia like AFib before. He wasn't certain of that, but that's what he think he may have had. Entresto was for heart failure. This is a diuretic. This is a very high dose. Normally, this is only 20 milligrams once a day. He was taking 120 milligrams a day. So he's extremely high dose of a diuretic. And again, he had not seen a physician or gotten labs in 8 months. He was on a statin. Statins, again, good for cholesterol, but it can also weaken the heart because it has an impact on the mitochondria. And he's on 2 different types of insulin, vitamin D, and potassium. So he came to his blood pressure 96/48. I was a little concerned with that. He's on heavy doses of medications. So we tweaked his meds. We weaned some of them. And we got blood the first day. So we got blood the first day. We didn't know the results. He came back 2 days later. And we got the blood results. His creatinine was 5.08. So he was, headed toward renal failure. And in fact, the GFR 14 puts him at end stage. So we gave him a lot of IV fluids because of this. And I'm going to show you his overall hospital course. So we saw him in hospital, we saw him in office on day one, got his blood, tweaked his meds, started him on detox, saw him, I think, 2 or 3 days after that, looked at these labs, On that day, we gave him intravenous fluids because I thought that, okay, super high dose of diuretics. I think you're dehydrated. I'm going to give you a liter of fluids, come back the next day. The next day he came back, his creatinine was even higher because we didn't, stop that trajectory fast enough. So at that time, we gave him more fluids, but we put him in the hospital. So to kind of give you the overview, here's the detox regimen, 0 to 4B. He started diuretic weaning, but we didn't wean it fast enough. Same with the other medications. We had to start off IV hydration. On the very first day we saw him back, we saw him that next day, his creatinine was still very high, so we had to put him in the hospital. So that's that course of action there. So what did we happen to do once we stopped all of these medications. Everything in red is stopped. We started biostolic in place of this other beta blocker. Vitamin D, we kept him on. We started him on coenzyme Q10. We put him on the E3 Live. That's a superfood. The CMOS, again, the superfood supplements, the CoQ10 supplement. And we put a lidoderm patch on his knees for his gout. And that allows us to take him off the allopurinol. So more topical treatment. So we streamlined his medical therapy in addition to detoxing him. And here's the course of action. The kidney function, creatinine went from 5.08 to 12, and it came down. This is aggressive IV hydration. Now, many doctors will be afraid of giving congestive heart failure patients IV fluids. Well, we had him in the hospital. We were monitoring. And so what we did is this. I gave him liter after liter. I think I may have given him 6 liters of IV fluid. I kid you not. And his creatinine, as long as creatinine got better, he felt better. The chest pain went away, all of that stuff. So his creatinine went from 5.08 to 12, back down to 1.8. The GFR, again, this red line denotes when you need dialysis. This is a GFR of about 15, actually a little bit above that. And this is at 12, and dialysis at 15. So he was below this, and many people may have just declared him in stage and started him on dialysis. But we said, no, let's give it medication weaning a try, aggressive hydration. And lo and behold, fortunately, his kidney function came back, not quite back to normal. But I think over time, it could come back to normal. Here's his functional status. We did a treadmill test. This is the blue one's a more aggressive test called the Bruce protocol. He was only able to do 1 minute on the very first day we saw him. It went up to over 3 minutes. It's almost quadrupled in time, so at least triple. The modified Bruce went from 12 to 13. So his functional status went up by 3-fold. His pre and post stress heart rates, it was very close pre and post, but then his resting heart rate went down and his peak exercise heart rate went up. So again, hemodynamically, he improved with better volume and nutritional detox. A shorter weight.
Question, just to clarify, for nutritional detox, was he juice, smoothie, or raw?
0 to 4B. So he was raw. He was able to have some of the dehydrated foods. So you had was able to eat the better than tuna sandwich or the raw pizza or something like that. Okay. In addition to smoothies and salads and juices. Okay. In the hospital, it was mostly salads because we didn't have, but we did get some of the dehydrated stuff to him. Mm-hmm. A good question. And this, the weight bounced around. Now here, over diuresis, and then we hydrated and went back up. But then it came back down over time with hydration, but better, the hydration itself was a diuretic effect. The blood pressure bounced around. Part of that's due to detox. Part of that's due to hydration. So he came in dehydrated, over medicated. We stopped medications or weaned medications and hydrate. So the number's going to bounce around a little bit, but they were never super high. So the blood pressure stayed within reasonable ranges. The heart rate bounced around. A lot of these hard numbers are due to detox when the body's pushing out toxins and catecholamine, and it came down a little bit. But again, we still had more work to do. He was from the East Coast. He had to go back home, but we really got him in a much stable condition and was able to follow him up telephone visits after that, and he continued to do well. The last segment I want to talk about is our supporting scientific data. And I want to show the science behind this, because one thing is it's great to talk about the theory, and it's great to say, oh, this patient came in and, we put them on detox and everybody was happy, but, and it's wonderful. But I want to show, we did show some biomarkers and some hemodynamics, but we've actually looked at this, scientifically. We actually have some upcoming studies as well. But we published and showed effectively that in the outpatient setting, much of what you saw just then, that you can effectively treat elevated cholesterol, blood pressure, with nutrition and reduced medication. Now, this is the population size. I'm not going to spend too much time on these slides because we're getting running up on time, and we'll save some time for questions or comments, etc. But this group that we recruited, basically the recruitment criteria or inclusion criteria were elevated cholesterol, elevated blood pressure, and elevated BMI. So these were the criteria that we shot for. We did not choose diabetes, even though about 27% of them were type 2 diabetics. Here's the food classification system in detail. I'm not going to go through this in a lot of detail, but basically food level 0 is raw liquefied food. So you could juice, cold pressed juice, a carrot. This is 0. Cold pressed juice or liquefied as a blender. As a smoothie is 0. 1 through 3 are solid raw foods. 1 is low glycemic index. 3 is high glycemic index. 2 is in the middle. 4 is a transition zone. 4A is high fat raw foods. 4B are dehydrated foods up to about 140 degrees, no more than 160 for sure. C, foods that could be blanched for less than 4 minutes, maybe boiled less than 10. 5 and 6 are boiled and steamed at longer durations of time. So these are like your cooked vegan foods, but not cooked in a microwave. Microwaving throws it out beyond 7. Same way as deep frying and heavy grilling. So this is kind of the food classification system in a nutshell. At some point, you can take a picture of that and take a closer look. Here just shows baseline food and the changes in what they ate. Notice there was a 9-fold increase in the amount of avocado consumption, but cholesterol still went down and weight went down. So a lot of people are nervous about avocados, but you can consume them. But here's some of the things that hemoglobin A1C we show, but what's more pertinent to this discussion is inflammation. So C-reactive protein reduced by 30%. We'll show that percentage in another slide. We did show hemoglobin A1C reduced. And there's an important thing here, I'll just highlight it, that this was not a group of people that were recruited based on diabetes. Again, the average hemoglobin A1C is 5.9. That put them in the pre-diabetes state, but it still went down by 0.2. And that's a 3.4% reduction in hemoglobin A1C in just 4 weeks. The hemoglobin A1C is an average of blood sugar over 3 months. We reduced it in 1 month, largely because we reduced the fluctuations. And so that's what happened there. Blood pressure went down. It bounced around a little bit, and we typically see that. The number of medications went down by 1 medication per person on average in 4 weeks. We showed a reduction in Lp(a) and inflammatory markers. And again, that applies here. So lipoprotein(a) went down by 16%. We were the first to show it in the medical literature with nutrition. Other lipid molecules went down. Weight, LDL, these things went down, of course. What's important, though, as I said before, C-reactive protein, inflammation. Remember, for those chronic illnesses, inflammation went down. And so that was a 30.7% reduction. IL-6, a cytokine, was significantly reduced. TNF-alpha did not go down significantly. Total white blood count, it started at 6.3, which is in the normal range, but a significant reduction, about 22% in white blood count. There's another marker that's showing inflammation is being reduced. Even though it started off at quote unquote normal, I think a lot of these people, that normal range is pretty broad. And a lot of people with a white count that's in normal range is relatively high because of some underlying inflammation. So I just wanted to go over that. It's a busy talk, but I wanted to kind of cover a lot of information in terms of how food can work, some of the mechanisms, some of the clues that we have in terms of how it's working, how it's being effective, and correlate that with patients. So one patient where we saw troponin levels come down immediately in a week, and he got better in that period of time. And you see these inflammatory markers go down. I'm planning another study, collaborating with Georgia State University. And I talked to the PhD grad student there, and we're going to measure a lot of biomarkers every week. And they're looking at the cellular level. They're going to look at gene expression, look at other inflammatory markers, and we're going to compare a defined plant-based diet compared to another popular diet, Mediterranean diet, and look at these biomarkers over time. because I think it's important. Everybody, and it's important to understand the long-term benefits of this. We understand that, but there are a lot of patients who have acute illness, and oftentimes we say, okay, well, forget about the diet now. Let's hurry up, get your cath, get your stent, get your this, and it's fine to do these things, but we need to bring to the forefront, say, hey, wait a minute, we're doing these acute interventions, and many patients can benefit, from these interventions, but they can also benefit from a nutritional detox, even if you need your cath, even if you need your surgery. In fact, I think you need the detox more so if you have to go through surgery, emergent or otherwise. More so, you have to have a heart cath or stent or any other procedure, because those procedures actually put stress on the body, inflammation, and increase oxidative stress. I'll be quiet and get comments from my esteemed colleagues or anybody in the chat room. Y'all are quiet in the chat room.
I wanted to ask something. So just into the future. So after you detox and you've kind of come out of this acute place, what is, for these patients that you gave us a sample of, what is the expectation for the rest of life? To stay raw, to, how strict do they have to be? 100%, 80-20? I know we want to stay whole food, plant-based, but where on a patient who has this type of heart disease and these other issues, where would you suggest that they stay?
Yeah, that's a great question. It all depends, but what I will say is this. Someone who starts this in the acute phase, as opposed to, let's say, someone who's that last category, chronic illness with no symptoms, is kind of elective. If I took the most acute and the least acute, I would say the most acute patient, I would say minimum 6 months or longer. Why? In the most acute state, let's say someone has bad heart failure. In fact, I'm treating a patient right now. I was on the phone with the nutritionist, and bad heart failure, was in hospitals, and everybody gave up on it. She was supposed to stop the melanoma. She was supposed to be in heaven now. She's not yet, thanks to God, but he's enabled us to help her, and she is detoxing. Now she's going to be on a raw detox for a prolonged period. We're talking months, at least a year. Why? We want to build up reserve. So the most acutely ill person need to be on there longer because they want to build up reserve. If they cheat after 2 months or 3 months, they can regress very rapidly. And I've had that happen. I've lost patients that way. So we really emphasize staying on it. And that's why we're working hard in the Nutrition Center to create detox-like foods, or detox-qualifying foods that have more savory taste. Hence the pizza, the raw toast, and things like that. So that helps them stay on it longer. So there's a culinary component to this, as well as a scientific and medical component to this. And so, I'm in the kitchen on a regular basis, working with my chefs and preps, people coming up with new menus. We got a fettuccine Alfredo and all of these things, because that helps them stay on raw. If you're just going to eat less the whole time, it's going to be very hard to stay on raw. Even the best intentioned person will have a hard time. But we have, high quality, very savory detox food to keep on for a long time. Now, the other extreme, the person who's minimal symptoms, we have a little bit of leeway because they likely I'll say, have more reserve. But I still tend to like to keep them on it for like 45 to 6 days to 6 months. But then in that situation, you can do more intermittent detoxing. So like you go 0 to 4B, then for a month, or let's say 6 weeks. Then you go 0 to 6 for a prolonged period of time, maybe 3 months, 4 months, then do another detox. So you may do detoxes every year. And in that situation, every detox is cleaning up your diet along the way. So you may come out 0 to 6. You may eat a lot of cooked foods or whatever. The next detox, you may cut your cooked foods in half, then in half again, and so on. So you get a higher quality raw diet. So depending on where you start, determines how aggressive you have to be, and helps us determine, how long we can detox or need to detox, and how much, breathing time we can give you.
Okay.
So anyway, okay. So here's Sean. Where can we find recipes? Raw pizza. Well, the raw pizza just coming out. We're going to have a lot of these recipes online. Soon we're going to have. I'm going to announce it on the show, but we're going to release we'll have an online detox program. It's going to release all these recipes and the like. So you'll have access to a lot of these recipes that we've And basically what we take is a lot of raw recipes and we re-engineer them, because oftentimes raw recipes have some things that you really don't want in a detox regimen. So anyway, stay tuned. Thanks, Ms. Moshe. How are you doing? You offer demos or class on how to prepare some of the foods like the better than tuna. We're going to have some better than tuna food demos online. So great questions anyway. But anyway, in summary, this is an approach that can really help. As I mentioned today, one of my patients, went in with heart failure, bad valve disease. One of my colleagues, said, look, we're not going to do the valve procedure. She's too far gone. Another, colleague said, well, she's too far gone. I'm not going to place the BIV, defibrillator. And so I said, okay. And we got palliative involved. Palliative said, well, we're going to stop the milrinone. Milrinone is a drug that sort of helps the heart beat effectively. We tend to send patients with bad heart failure home on it, usually to die. But if they go to hospitals, we stop it in the hospital and whatnot. So the palliative team got in place. And so I said, well, we're going to stop the milrinone and you'll probably die within a few hours or days or whatever the case is. I went after this, talked to the patient. And so I said, well, and I didn't know what palliative had said. So I said, well, I'm going to start you on some smoothies and, raw kale. And this is after everybody had given up. So I'm saying, okay, here's what we're going to do. And so I was thinking about what I was going to have for my last meal. And she started crying and stuff. And I said, look, stop that. You're not going to have your last meal. Here's what we're going to do. And what we did is we put on a detox, and I was able to wean the milrinone down to 0 within a week's time. So I weaned the milrinone and was able to discharge her off milrinone. So we had to go to a nursing home for hospice. And she was doing so well, she left the nursing home in less than 2 days. She didn't stay there much time at all. And I called her this weekend and she says, I'm feeling great. And so it's a matter of getting physical therapy and whatnot. So this program works. And there's another patient in his 40s and came down from South Illinois. And again, bad heart failure, AFib, et cetera, et cetera. The other patient in his 70s and this patient in his 40s. Again, we detoxed him, weaned him off milrinone. He's doing great. And so, these patients can turn around. It's not easy. I mean, I'm showing this. We had some failures, and we've learned from those failures. And we're doing some things now differently than what we've done maybe a year or two ago. And we're getting some success with that. So these acutely ill patients can be very challenging, very difficult. But because they're very challenging, because they're very difficult, is the reason why we have to add this awesome, intervention, nutritional detox. My colleagues that we work very hard managing some of the sickest patients around. And if we only put them on an aggressive nutritional detox, these other things, that would make life better for everybody, and including the patient. So that's my take on it.
One thing I want to say before we go is for the audience to realize that, we talk about detox, we talk about this, but actually it is a lifestyle change for us and for patients I coach and talk to. I want them to know that you're really not going back, because, what you had done up to that point in your life, the path you've chosen has gotten you into the position you're in. And so if you continue to say, well, when can I, go back and add some things? Well, you're just reversing what you've done. So, and I know it's difficult. I know it's hard for some people, but they have to make that choice. Are they ready to move forward? And it's a transition. It's more than a detox. When people say detox, they feel that I have a tool that I can do something with. But that tool doesn't stop there. There's no, I used to say, well, we have a maintenance program that goes along with it. And people say, okay, they can deal with that word maintenance. But what I'm saying to myself, it's a lifestyle change. You're never going back, because if you go back, you might as well, with that melanoma, you might as well get the melanoma out and call the priest and all of those things, because that's where you're headed. That's where we're pulling you back from. So if you make up your mind that I'm not, that I'm going to not go down the path, I'm going to choose another path, and we're going to walk this other path. So don't think about where you were before, because if you think about it, you won't be there. So I want to share that with the audience to know that this is a lifestyle change. It's not an option. There's no plan B. This is plan A, B, and C. And I guess the most critical thing that you're doing, Baxter, for them is providing, and what we need to do more of is provide them those choices that make them stick with that program. Because right now, if we don't provide the food or the recipes or the nutrition, people don't know which way to go. So that makes it more difficult. So we want to work on that a little bit more.
Yeah. No, I think you're right. And it's an ongoing process, You're coming up with new recipes, new options, and we've just been learning along the way. And it's, our more challenging patients are the more educational patients, and so they help us improve our programs. So,
Dr. I wanted to also, and maybe Dr. Atkins can speak to this, more so something for you all to speak on, because you all do more detoxing of adults than I get to do in children. But also the fact that it's not necessarily, when you take these patients off of their medicines and you are switching things up, the patient is having what they feel, they may be having headaches or stomach aches. So what do you say, what patients should expect that they're going to have some changes? And it's not always, I'm waking up and feeling more energetic and all of these good things that you hear on TV. You may get some negative first before you get to the positive. Because I've had a patient say to me, well, maybe that's not for me, meaning the raw food diet is not for me. So what do you say to patients that feel like that because they're getting some of the negative effects of initially starting into this detox?
Yeah, that's a good question. And the thing is that what I tell them is that when you're feeling pain and headache, that means it's working.
Exactly.
That's working, and you got your disease state where you want it, and it's taken effect, and just let the process work through. The whole issue is not for me, not for everybody. Good health, I think, is for everybody. Feeling good, I think, is for everybody. Being in control of your own health, I think, is for everybody. And at the very beginning, it may feel like, wait a minute, this is not for me. I remember my first, juice feast. It's like, wow, the first days, sinuses were running, everything's crazy. My juicer broke, all sorts of crazy stuff is going on. But over time, I got through that process, and I got on the other side. I said, wow, I feel great. But even then, after the first juice feast, there was a whole journey of sticking with a plant-based diet, which, was very easy because I was eating some junk plant foods. But as I went through that process and cleaned up the diet even more, again, that was another phase of the journey. And so, I would tell them, think of a long trip. You're taking a drive for vacation, and you're on the road, and then you're going to go through some rain and maybe a little bit of snow, depending on what part of the country you're driving on. And you might even have a flat tire, have to go to the mechanic. But that's part of the journey. But you work through those things, and on the other side is your vacation destination. And that's what I try to tell them, say, yeah, this is a journey, and every journey has highs and lows, there are pitfalls and bumps. But enjoy the bumps as well as the smooth part of the road, because it's all part of the journey. And keep your head up. And when you get to the destination, you can look back and you can savor the beauty of the journey, because the potholes and the flat tires, all those things are part of the journey. I look back on trips I've taken, and certain things happen, the kids acting up. And, it wasn't fun in that moment, but you look back and laugh about it. So tell them it's part of the journey. Just sit back and enjoy and don't complain.
Exactly.
So, but no, that's a great question. Let's see. Great reminders, lifestyle change. She's like that. Let me see if y'all see any questions that we need to address before we check out. What should I eat after I do a 28-day raw detox? Depends on the type of detox. Like if you're doing a juice feast, I wouldn't eat beans the very next day. But if it's 0 to 4B, you can get some beans. I'm actually looking into doing more sprouted beans and more raw sprouts. So I would also add sprouts even during the detox and after as well.
Somebody asked a while ago about when you were weaning medicines, was it in the hospital only or outpatient?
Most of our medication weaning is an outpatient, but we do it both places. So we do aggressive weans in the office. We whack away. Somebody will walk in with 20 medications, and they'll walk out with 5 or 10. After we go through them, and we do frequent visits. So we may see them 4 days later, call them 2 days and see them 4 days. So it depends on what change we make and what we need to do. But we see them minimally weekly during the detox and aggressive medication wean. So we're not shy about weaning the medications, and we're not shy largely because the medications in many cases, if not every case, is contributing to the underlying illness.
That same person asked about a statin her dad is on. She heard it was dangerous to take that off.
Yeah, we say a lot of things are dangerous. I'm not aware of any studies showing acute coronary syndrome due to removal of a statin drug. Cholesterol can go up, but the statins have two notable benefits. One, reducing cholesterol, LDL cholesterol in particular, and the other is reduction in inflammation. So when we looked at, if you look at, I forget the trial, AstraZeneca was the company that did it, but they had rosuvastatin was a statin drug, and they found in that study, they did, I think, subgroup analysis, they found in that study that there was a significant reduction in C-reactive protein. But they had about a 35% reduction in C-reactive protein in about a year and a half. Our data shows a raw diet of 30+% reduction in C-reactive protein in 4 weeks. 4 weeks versus a year and a half. Yeah. And so if you reduce the statin, it's a year and a half worth of effects. It's probably going to reverse very slowly. If you reduce it in the setting of a raw detox diet, you're reducing LDL cholesterol and you're reducing the statin. So if you're on a raw diet and you take away the statin, the raw diet, I showed you scientific evidence, to reduce LDL cholesterol and reduce inflammation. The statin reduces LDL cholesterol and reduce inflammation. But the statin does not reduce lipoprotein A. The raw diet does. So if you're looking at lipid profile with the raw diet, reduction in LDL cholesterol, reduction in inflammation, and reduction in lipoprotein A in just 4 weeks. Statin, year and a half. So the question is not if it's dangerous to reduce the statin. The question is it dangerous to not be on the raw fruits and vegetable diet?
Exactly, because our levels are not elevated because of the statin drugs. Is elevated because of the diet. So people, right. It's like people got the whole script flipped. That it's always the drug and it's not the diet. But it goes back to what I always say, and what people just take for granted, that you are what you eat. So when you eat those things, it's going to cause the numbers in your life to change. So if you change what you eat, if you want to change those numbers, you got to change what you eat. And you can't say, well, I can go, and I guess I'm being hardcore tonight because I don't, people want to take holidays on the food, or I'm going to eat this 7 days, 6 days, and this one day. But that's the one day of poison. That's the one day I have myself set back. That's the one day my numbers are going to flip. That's the one day I'm going to begin having headaches again or having problems again. So you want to understand that it's not this. Your level's not elevated because you don't have a statin. You don't have inflammation because you don't have a statin. You have inflammation because of the diet. You have elevated numbers because of the diet. And I'm just re-emphasizing what Baxter said.
No, I agree with you 100%. And that one diet could actually lead to a heart attack or stroke. I had a lady that had eaten fried chicken through the weekend and came in with bilateral blood clots to the lung. And so that one meal can take you out of here. So especially if you have a vulnerable plaque, you put fried chicken in your mouth, that's like a flame torch going through your vessels. And that can cause a lot of heck. And so that's a critical factor. Let's see here. Let me just go through some of these other questions. You guys wait till last minute to ask questions. That's great. They're great. Any advice on how a person can stay motivated with staying with raw food lifestyle?
A lot of those questions in this group are basically people finishing up detox. What's next? How do you stay motivated? Kind of what we were talking about. Beyond. Yeah,
somebody say stay in supportive groups like this one. I think that's good. The key is, and what I've done over time is, and it might be too late if they're coming out of detox, but during the detox, like if I'm doing a juice feast or whatever, my mind, I'm planning a strategy. I'm planning a post-detox strategy. And I'm planning my meals in my mind. What am I going to eat? So if I'm on a long juice feast, I'm saying, okay, in fact, I'm coming up with recipes. Okay, I'm going to do this, I'm going to do that. And so you can map out your first 10 to 15 days of recipes, keep the momentum going. The other thing you do, like we said before, find out supportive groups, find restaurants, a place where you can eat. You know what your lifestyle is. You may be very busy. You don't have time to prepare your food. Find key restaurants. I don't care if there are 2 places in your city. If you live in Houston, I used to just drive all over the place. I would go out of my way to a certain place to get the food I want. And I'll get a lot of it. If I'm flying somewhere, I'm traveling, I will Google raw vegan restaurant, find a place. Oh, it's over here. Sometimes I get off the plane, I get a car to take me to that place. I'll order a bunch of food, take it to the hotel. So you have to be intentional. I think that's the one thing. Find a supportive group, be intentional, and always plan your food. At the beginning, you have to think about it a lot. It's sort of like when you learn how to drive a car, you think, brake, go or whatever, automatic, clutch, shift, all that stuff. You got to think about it. After a while, it becomes automatic. Riding a bicycle becomes automatic after a while. So you have to plan, be intentional, and don't backslide, because you get in the habit of backsliding. But stay on top of it. And as you stay on top, it becomes more and more natural.
And what I want to say is, and now with me and Dr. Pam, we do challenges. I have an Instagram page, and people can write this down because I post pictures of what I have for lunch, what did I eat today, and she started doing it. And so we have challenges on making dishes. So, and it's not like you have to have a recipe. We take certain foods, we prepare a plant-based dish. We try to keep it raw 80 to 90% of the time. But my Instagram is Living Well with Dr. Floyd. Living Well with Dr. Floyd. Hers is the Dr. Pam. And if you look on the Instagram page, she posts, what I ate today, what's for lunch. And you can see the pictures. She gives a description of the food. And I want people to
DR?
Was that
Doctor
yeah, DR. No, the Dr. DR Pam. The Dr. Pam, and is Living Well with Dr. Floyd. But she posts things, and so she challenges me. So when I see her post something, I go into the kitchen and I say, I'm going to make another dish, and I'll make my dish. But I would welcome people to post their dishes, join it and post their dishes, and you can get so many ideas. I take some of her dishes and I steal her ideas, and I make another dish out of it. But right now we are making a quinoa pizza crust, and we make a red seed lentil crust. We make wraps. We make dishes from so many. Some of them are fruit based. I will do smoothies from time to time because I have about 20 different recipes for different smoothies just to mix it up. So there are options, but you have to connect with a group who's doing that. You have to be in that circle. But if you're in a circle with everybody that's going to McDonald's or going to Chick-fil-A, you get a different outcome.
That's right. And again, you have to be very selective and intentional about what you eat. Somebody asked about the difference between 4B and 6. Food level 4B is dehydrated food, so they're warmed up to about 120 degrees. So we have a raw pizza bread that we only warm up to 120 degrees, and it tastes just like regular pizza. And then the other things. The dehydration allows you to play with the textures of foods to give you some of the savory taste that you're used to. 5 and 6 are steamed and boiled foods. Those are your soups and things like that. So again, those are your cooked vegan foods, but it's cooked in a healthy way. And so that's the spectrum there. Somebody's got it all written up here. So, all right, we got a food. Somebody took notes, so as an expert there. They probably have it in the book. Cannot find the IG. Can you post here? What's up?
The Instagram.
Oh, Instagram. What? I typed in Living with Dr. Floyd.
Living Well.
Living Well, Dr. Floyd.
Living Well with Dr. Floyd.
Okay.
Living Well with Dr. Floyd. And
the Dr. Pam?
Yeah, THEDRPAM. The Dr. Pam.
All right. So,
but yeah, follow us and we'll follow you, and we can share.
Good deal. Well, this has been another fun Monday. Guys, thank you very much. I'm going to see you backstage. I'll go close out. Again, our overall theme here in this show is to empower you with knowledge, empower you with the tools, techniques, the motivation, to do the right thing. And this talk was to, in part, give you insight into the broad scope of this lifestyle approach. You may have loved ones who are acutely ill. You can help them out. If you're visiting someone in the hospital, you could take them raw plant-based foods. You could take them, super greens or algae. Don't stand by and just be helpless. You can do these things. Encourage them to eat just the healthy food. Hospitals will let family members take food to loved ones just by giving them healthy food in the hospital. Healthy food, maybe in a nursing home, can help turn the illness around and improve their overall well-being. And so this is something that can really make a difference in someone's life, regardless of what stage of illness they're at. So hopefully you found this to be helpful. If you did, please subscribe if you haven't subscribed. Hit the thumbs up button. That helps us tremendously in our algorithm. And of course, share this with anyone and everyone you think may benefit from this information, because the more we get the word out, the bigger our audience grows, and the bigger our audience grows, the more we're able to do with this information. So we look forward to seeing you next Monday. And until then, keep it fresh, natural, and live.